Well, it's a pleasure to be here, and I'd like to thank Serge and Rami for the invitation to speak to you today. So I'm going to talk about a topic for which there are many questions and unfortunately few answers. We'll start with a clinical case, a 68-year-old male with diagnosis of primary myelofibrosis diagnosed in 2012. On initial bone marrow, the patient had a hypercellular marrow with trilineage hematopoiesis, 2+ reticulin fibrosis, no increase in blast genetics, notable for JAK2 mutation as well as an ASXL1 mutation. Initially, the patient was treated with Rux 10 milligrams twice daily for symptomatic splenomegaly. Over a period of years, the patient became more and more fatigued and was noted to have increasing leukocytosis, now up to 75,000 from a baseline in the 10,000s. Bone marrow was repeated, which was again hypercellular with 40% blasts now noted. Cytogenetics demonstrated a new monosomy 7 and 40% of metaphases. Availability of a matched donor was uncertain at this point. So the question is, what is the optimal approach to the treatment of this patient? Do we induce this patient with AML therapy? Do we give this patient a hypomethylating agent? Do we take the patient straight to transplant? There's some data that we can use to guide these decisions, but I think large-scale data is lacking. So to talk about this in a little bit more context, what do we know about leukemic transformation and the natural history of this in patients with MPNs? The estimated risk is highest in patients with myelofibrosis, about 20.6% at 100 months from diagnosis, followed by PV with 8.7% and ET, the lowest risk at 4%. Now, thinking about secondary leukemia as a whole, secondary leukemias, if we think about de novo versus secondary, they account for about roughly a quarter of all leukemia cases. The majority of those do seem to come from myelodysplastic syndrome, but roughly 25% of secondary AMLs would arise from ET-PV or myelofibrosis. Now, in terms of how patients do overall across the board with AML, either primary or secondary, it's the patients who have AML derived from an MPN who do the worst. The patients who have AML with derived from MDS seem to do a little bit better than the MPN-derived patients, and all of them do worse than de novo AML patients. So what are some of the risk factors that we know of empirically? Well, in patients with ET, a particularly high platelet count, in PV patients in age greater than 70, and a variety of different things in patients with MF, such as a high leukocyte count, peripheral blast greater than 3%, a bone marrow blast greater than 10%, or a monosomal karyotype. We certainly worry about treatment-related impact on the risk of transformation. And over the years, a number of agents have been looked at retrospectively in terms of their risk of producing leukemic transformation. What's emerged from that data is that certain drugs, such as busulfan and more historic drugs, I would say like piperacillin or P32, seem to be associated with an increased risk of transformation. Other data have also implicated drugs like danazol or erythropoietin-stimulating agents. Again, part of the conundrum here is, are these just sicker patients who need treatment, or are these agents actually producing transformation? So from the genetics, we know that there is some differences between JAK, MPL, calreticulin, but by and large, the major risk seems to come from the quote-unquote triple-negative patients, the patients who bear none of the canonical mutations in these genes. Who these patients are is something that I think a number of groups, including us, are trying to investigate to better define exactly what the mutations or even potentially translocations are that drive disease in these patients. It's important to remember that these are not the JAK-STAT activating mutations are not the end of the story. We know that there are a number of other mutations that seem to be both recurrent and important prognostically for patients with MPNs. Things like epigenetic modifiers like IDH1 and 2, TET2, ASXL1, EZH2, and increasingly the splicing factor mutations. Along those lines, what has been determined or described thus far is that several mutations seem to have a negative prognostic impact in terms of the risk of leukemic transformation. Most, particularly ASXL1, but also SRSF2, EZH2, and IDH1 and 2 mutations. It's also important to remember that the genomics of a given patient are not necessarily static. And we might obtain a genetic profile, for example, in a patient at baseline. That doesn't mean that that is the profile that patient is going to stay with necessarily for years. And this was a really nice retrospective paper by Radek Skoda's group that looked at patient materials that were plated in methylcellulose to derive the clonal history of the patients. And as you can see in these examples, the clonal history can be quite complex. For example, if you look at the top panel where this patient acquired a number of mutations over time, but certainly the patterns that we see, particularly with transformation, could include things like calreticulin followed by TET2. So we have to keep that in mind when we are, I think, first evaluating a MPN patient, but an MF patient in particular. So we take this to another level and look at the frequency of some mutations at both the chronic phase and at the time of blast phase progression. Certain patterns certainly emerge. So for example, if we look at TET2 mutations, these are relatively infrequent events in chronic phase, but they account for about 18% of mutational events at the time of transformation. And this is particularly striking for mutations like ASXL1 and IDH1 and 2, where IDH1 and 2 mutations are really quite infrequent in chronic phase, but they occur in 21 to 31% of patients at the time of transformation. And P53 is, I think, among the most notable, and this has been described by a number of groups. So this pattern gives rise to the following model, which is that patients may acquire mutations in a serial fashion over time, which ultimately leads to leukemic transformation. Now, I think this is a hypothesis, and we'll talk about a little bit of data that supports this particular model, but also some alternative models. So in collaboration with Dr. Strovzek a few years ago, we undertook a large-scale genomic analysis of post-MPN AML patients. And this is showing you the frequency of mutations at the time of leukemic transformation. And in terms of the mutations that we see mutations like JAK2, ASXL1, P53, splicing factor mutations as relatively frequent events at the time of leukemic transformation. There's a couple of interesting points to be made from that observation. Number one, if we think about the genetics of de novo AML, it's very clear that the frequencies of mutations that we see in de novo AML are very different from what we see in post-MPN AML. So for example, things like FUT3 mutations, among the most frequent mutations that we observe in de novo AML, are very, very infrequent in secondary AMLs. And the same thing is true of DNMT3A mutations. On the opposite side of things, JAK2 mutations and SRSF2 mutations are very infrequent in de novo AML. If we also compare this to secondary AML that arises from MDS, we also start to see some differing patterns. The arrows are pointing to mutations that are enriched in patients with post-MPN AML. And if you look here at the top, certainly splicing factor mutations are highly enriched in both types of secondary leukemia, but things like IDH mutations and P53 mutations seem to be particularly enriched in patients with post-MPN AML as opposed to post-MDS AML. And so this tells us that on a genetic level, de novo AML, post-MDS AML, and post-MPN AML are not the same thing. So we had talked about P53 being one of the most frequent mutations that we observe. If we look at this on a clonal level in patients where we've had both chronic phase MPN and the AML sample, and we look at the sequencing, what we see is that if you look at the variant allele frequency, frequently you see an increase in JAK2 mutation variant allele frequency as well as P53, whereas many other mutations remain relatively static. And this suggests that this is a route to transformation. And if you look at one patient sample here, for example, there's an increase in the P53 and JAK2 allele burden that coincides with the increase in blasts in this patient from 4% to 70%. So does this actually biologically work? Well, we addressed this doing an experiment where we took p53 null mice and injected them with retrovirally transduced JAK2, and these mice develop a fulminant leukemia, as you can see here, which I think credentials the genetic observations that we have in humans. And so this represents one path to leukemic transformation. But looking at the genetic clonality very carefully, this isn't the only route to transformation, meaning that the serial acquisition of mutations it doesn't appear to be the only route. There are, it looks like, multiple pathways. So this is the model we've talked about where mutations are acquired on the backdrop of a chronic phase MPN. But there are other models whereby a common clone seems to give rise to both the leukemia and to the MPN, where a similar clone is seen with just increases in the variant allele frequency at the time of transformation, or where an entirely different clone emerges at the time of transformation as opposed to what is seen at chronic phase disease. So this argues that there are multiple routes to transformation, and this requires further credentialing, which is something we're working on currently. So JAK and ASX and TET2 don't seem to have any impact on how patients do upon transformation, but interestingly, patients with SRSF2 mutations seem to do particularly poorly at time of transformation. So there is some genetic heterogeneity even at the time of transformation. So what do we do about this? Well, as we've talked about, response to therapy has been far from optimal. And in fact, old data from Ruben Mesa has demonstrated that the impact of induction chemotherapy seems to be quite limited. So the genetics and the biology are telling us that this is a different disease. So what do we know from past experience? Well, looking at a series from the Princess Margaret group, if we look at the impact of induction chemotherapy, about 32% of patients in their hands achieved a CR or CRI. About 24% of patients had reversion to chronic phase MPN, but 36% of patients were resistant to treatment, and about 8% of patients had induction-related death. And this was similar to what was seen with some other induction regimens that they used. So these are, I would argue, data that are somewhat disparate from what we would expect with de novo AML. Hypomethylating agents have certainly been employed in many of these patients, and data from Mount Sinai using Decitabine in a small number of patients had demonstrated some degree of prolonged survival in patients treated with Decitabine, particularly those who went on to get allogeneic stem cell transplant. A larger series of patients was looked at with azacitidine, in which this study looked at patients with MPN who transformed to AML or to a more MDS phenotype. And the composite CR/CRI PR was 38% here, but the true CR rate was only 8% with AML. With azacitidine, I mean. Ruxolitinib has been studied, and this is data from MD Anderson. And this was a study that looked at ruxolitinib in 18 patients with refractory AML, 3 of whom were post-MPN AML. And in this particular study, 3 of 18 of those patients were able to achieve a CR with single-agent ruxolitinib at higher than utilized doses for MPN. But another study from MD Anderson had looked at another series of patients with post-MPN AML treated with Rux, and in this case, there were no CRs observed. So the data is not painting a picture in one particular direction. So if we come back to the idea of induction and of doing the standard approach that we would pursue with a de novo AML patient, this was looked at by the Princess Margaret group, where they allocated patients to a curative intent regimen, meaning that they got induction chemotherapy. If they got a CR, CRI, or reverted to chronic phase disease, they were then transplanted if a donor was available. And some patients were allocated to the non-curative intent, where they were given non-intensive chemotherapy but were allowed to be transplanted if they achieved a CR. So what this data showed is that the patients who were in the curative intent arm did better than those who were in the non-curative intent arm. In terms of the patients who achieved a response, a CR, CRI, or a chronic phase MPN status, those who were transplanted had a better outcome than those who were not transplanted. And in fact, if you take a look at this group of patients who had a response but were not transplanted, they did not do any better than those who had non-intensive chemotherapy. And this makes an important point because this begins to tell us how we might think about who should get induction with chemotherapy. Simply achieving a remission doesn't appear to do anything in terms of patient survival. And the other issue is that we need to begin to know who are these patients who respond, and that's going to require more careful analysis biologically and genomically. So what about allogeneic stem cell transplant in post-MPN AML? Well, a number of series have looked at this retrospectively, and that it appears that altogether the overall survival rate from this one series that used various different donor types, including umbilical cord, bone marrow, or peripheral blood, showed a survival about 29.2% at 2 years. We'll skip this slide. In terms of what does remission status mean prior to transplant, it doesn't surprise anybody that patients who have a CR prior to transplant have a better outcome. But it's important if you look at this particular graph, even patients who didn't achieve a CR who went to allotransplant, there was about a 20 to 21% long-term benefit to those patients. So there is still a potential role for transplant even in the absence of induction chemotherapy and the achievement of a complete remission. So certainly no one should be satisfied with this. I don't think any of us are in this room, and we need novel approaches to therapy. So one recent thing that we have undertaken is using the mouse model I briefly talked about. We've looked at the combination of Ruxolitinib and Decitabine, and John Mascarenas talked about this a little bit yesterday. But in our hands, preclinically, when we combine these agents, there seems to be a synergistic effect. And so this laid the foundation for a phase 1, phase 2 study that we have recently completed accruing to. And I'm just going to show you some data briefly from the phase 1 trial. This was a combination of Decitabine and Ruxolitinib, where Rux was given as a run-in for 7 days, followed by standard Decitabine 20 milligrams per meter squared for 5 days, and cycles were repeated. During the phase 1 portion, we started at 10 milligrams twice daily of Rux and escalated to 50 milligrams twice daily. In terms of the toxicities that we observed, we certainly did see cytopenias as would be expected in a number of patients in all cohorts, and infectious complications that coincided with that also in a number of patients, particularly at higher doses. But importantly, the DLT rate was below 33% for all doses, so no MTD was reached in this study. In terms of reasons for discontinuation, most of this had to do with adverse events, particularly at higher doses. Responses in the study, and again, there's no standard response criteria for post-MPN AML, and it's particularly difficult because you can't really get an aspirate on most patients. These are modified Chiasson criteria that look at the reduction in peripheral blood blasts, and the composite response rate was about 57%. This is CR, CRI, and PR. And we saw about 50 to 67% response rates in all cohorts, all dosing cohorts. The bone marrow histopathology demonstrated largely stable reticulin fibrosis with some cases of a decrease and some cases of an increase in fibrosis. Spleen size was reduced at all dosing levels as expected. And in terms of survival, and again, this is only from the phase 1 portion, the overall survival was 10.4 months. There was really no difference observed at the initial analysis between the dosing cohorts. So this has gone on to a phase 2 trial, which has just completed accrual, and we used 25 milligrams twice daily of Rux in cycle 1, followed by 10 milligrams twice daily for all subsequent doses, and we hope to share that data soon. A similar trial was is being performed by the MD Anderson group, and this is data from Dr. Bose, just demonstrating their phase 1 experience with a median survival of 6.8 months, and they're actually using 50 milligrams twice daily of Rux for their study. So other approaches are certainly needed. Preclinically, we've looked at other compounds such as heat shock protein inhibitors, which I think can have impact on a wide variety of leukemogenic pathways, and we've certainly seen survival benefits in mice treated with these compounds. And you start to see some differentiation in mice treated with heat shock inhibitor proteins versus Rux or just placebo. And Kapbala's group at MD Anderson has looked at other compounds such as BET inhibitors such as JQ1 and have seen in leukemia cell lines, these are HAL cell lines, increased apoptosis with these drugs. So certainly much remains to be done in this space. So to conclude, there are several clinical factors that we know of for leukemic transformation. We know that mutations in ASXL1, EZH2, IDH1 and 2, and SRSF2 are associated with an increased risk of transformation. The genomics of the disease and indeed the biology and the natural history tell us that this is a different disease from de novo AML, and I would argue in some respect a different disease from post-MDS AML. The effect of standard induction therapy is variable. There is a population of patients who seem to benefit from this, but we have to figure out who those patients actually are and define those patients. Transplant does offer a curative potential for these patients, even if they're not in remission, but certainly only in the minority of patients. And finally, we need to identify novel therapeutic strategies, and this is the work that we and other groups are carrying on. So with that, I'd be happy to take any questions.